My name is Hans Lee from MD Anderson Cancer Center in Houston, Texas. I'm an associate professor in the Department of Lymphoma Myeloma and the director of multiple myeloma clinical research. And today I'm going to be providing a summary of an abstract that was presented at the ASH23 meeting in San Diego entitled Patterns of Response to 200 milligram linvoseltamab in patients with relapsed refractory multiple myeloma, longer follow-up of the Linker-MM1 study. So linvoseltamab is a BCMA bispecific T-cell antibody that's being studied in the Linker-MM1 study. At this year's ASH meeting, we reported updated results in the 200 milligram phase 2 cohort of the Linker-MM1 study, which is the recommended dose of linvoseltamab moving forward. And this update is important for two reasons. First, this update reports a longer median follow-up of 8.1 months compared to previous updates at the ASCO and EHA meetings earlier in 2023. And secondly, this is the first time that the primary endpoints of the study has been reported, which is overall response rate as adjudicated by the Independent Review Committee, or IRC. This is a slide that describes the study design of the Linker-MM1 study, specifically the phase 2 study design. The key eligibility criteria of the study included patients with relapsed refractory multiple myeloma with at least 3 prior lines of therapy, including a protein inhibitor, immune modulator drug, and an anti-CD38 monoclonal antibody, or who were triple-class refractory regardless of lines of prior therapy. And patients who were enrolled on the study in the 200 milligram cohort then received linvoseltamab initially with 2 step-up doses of 5 milligrams and 25 milligrams dosed 1 week apart, with a 24-hour hospitalization after each of the first 2 step-up doses for CRS monitoring. Subsequently, patients then received the target dose of 200 milligrams linvoseltamab weekly on weeks 3 through 14, which was then de-escalated to every other week for weeks 16 through 23. And starting on week 24 or cycle 6, patients then could further de-escalate in a response-adapted approach to every 4-week dosing if attaining a very good partial response or better. These are the baseline patient characteristics of patients dosed in the 200 milligram cohort. Patients were heavily pretreated with a median of 5 prior lines of therapy. Approximately 80% of patients were triple-class refractory. Over a quarter of patients were over the age of 75. 17% of patients were Black or African American, and 39% of patients had high-risk cytogenetics defined as deletion 17p, translocation 414, or translocation 1416. This slide shows the overall response rate as per the IRC, which was 69%, with the majority of patients attaining a very good partial response or better of 59%. The median time to response was quite rapid at 1 month. The median time to very good partial response or better was 2 months, and the median time to complete response or better was 7.6 months. Notably, among patients who had prior BCMA exposure with belantamab vedotin, the overall response rate was 70%. And among patients with a complete response or stringent complete response available MRD data, half of these patients, half of the 37 patients with available MRD data were MRD negative at sensitivity of 10 to the minus 5. I did want to mention that during the week of ASH, there was actually a press release of an even later data cut of a median follow-up of 11 months that was reported that showed actually an even higher overall response rate as adjudicated by IRC of 71% and a complete response rate of 46%, which really highlights that response do seem to deepen with additional time on therapy. And the swimmer's plot indeed shows that this is the case. As you can see, that responses were early, durable, and deepened with time. And at a median follow-up, again, of 8.1 months, 50% of patients who enrolled on the study are still ongoing therapy with linvoseltamab. The median duration of response has not been reached at the median follow-up of 8.1 months. The median or estimated 9-month duration of response was 87%. Similarly, the median progression-free survival at the current follow-up of 8.1 months has not been reached. The estimated 9-month progression-free survival was 73% with this data cutoff. In terms of adverse events, the most common adverse event was cytokine release syndrome, or CRS. The most common grade 3 or higher adverse events were anemia, neutropenia, and thrombocytopenia. ICANS of any grade occurred in approximately 8% of patients, and treatment-emergent adverse events leading to death while on treatment or within 30 days following the last dose of linvoseltamab were reported in 13 patients, majority being due to infections occurred in 10 patients. Looking a little bit more in detail on infections, the rate of grade 3 or higher infections was 37%. The majority of these were related to COVID-19, which might be expected given that the study was enrolling during the COVID endemic era. There were 5 cases of PJP pneumonia, and notably all cases of PJP occurred prior to the institution of mandatory PJP prophylaxis. Looking in more detail on the analysis of CRS, this sunburst plot shows in more detail the characteristics and onset of CRS in patients receiving linvoseltamab, the 200 milligram cohort. As mentioned earlier, the incidence of CRS is relatively low at 46%, the majority being grade 1 in severity. There were 9% grade 2 CRS cases, 1 single grade 3 CRS event, and no grade 4, grade 5 CRS events. CRS typically occurred during the initial first 2 step-up doses, and the usage of tocilizumab was fairly low at 21% across the study. And notably, the kinetics of CRS were quite rapid. So the median time to onset of CRS was less than 24 hours, with resolution typically within 1 day, which is typical with the IV formulation of bispecifics, given the pharmacokinetics of IV bispecifics that we see. So in summary, at a median follow-up of 8.1 months, linvoseltamab induced high response rates that deepened further since the last data cut. The overall response rate, as per the IRC, at this particular data cut was 69%, majority attaining a VGPR or better. Responses were also early and durable. And one thing to note is that there was, per protocol, rapid de-escalation of the frequency of dosing of linvoseltamab. So again, patients were able to de-escalate to every 4-week dosing starting week 24 or cycle 6 onwards, and patients attaining a VGPR or better. Linvoseltamab also showed a generally manageable safety profile. The CRS rates were relatively low at 46%, the majority being grade 1 in severity. And the predictable timing and low rate of CRS with a rapid onset and resolution of CRS within 24 hours really allowed for a minimal inpatient monitoring schedule for CRS monitoring of only 24 hours on week 1, day 1, on week 2, day 1 during the step-up dosing phase, which is convenient for patients. And so based on this promising data, additional studies with linvoseltamab are currently ongoing. Notably, the Linker-MM1 study is a phase 3 randomized study evaluating linvoseltamab compared to standard of care elotuzumab, pomalidomide, and dexamethasone in earlier relapsed refractory multiple myeloma. The Linker-MM2 study is evaluating linvoseltamab in combination with other standard of care myeloma agents in relapsed refractory multiple myeloma. And finally, the Linker-MM4 study is evaluating linvoseltamab as a single agent initially in newly diagnosed multiple myeloma patients. Thank you for your attention.